Hi guys, welcome everyone to the quick recap of the important topics for the upcoming INI-CET. So let me tell you that the focus of today's discussion is the students who are going to give the upcoming INI-CET on 9th and not for those who are preparing for the subsequent exams. So I'm not going to be very detailed because it's about in quick time, whatever we can squeeze the important facts and figures that we will try to squeeze. Those who want to know any topic in more detailed manner, connect me personally through DM or go through my Reed Harrison videos where most of the topics would be already addressed. Right? So today let us keep it succinct, focused on the important points required for the upcoming INI-CET. So let me start without wasting the time on cardiology. What are the important topics from cardiology? If you ask me to pick 5 important topics from cardiology, number one, I'm not going to count valvular heart diseases. Number one, it will be AV blocks and arrhythmias. Number two, the pericardial diseases. Number three, cardiomyopathies with special focus on hypertrophic obstructive cardiomyopathy, right? And then infective endocarditis. Infective endocarditis is already addressed in microbiology. So let me start with the pericardial diseases, right? So what are the important pericardial diseases that you know? Pericardial diseases. So when I talk about pericardial diseases, three things come to my mind. Acute pericarditis, chronic constrictive pericarditis, and cardiac tamponade, right? So let us first start with the pericardial diseases. Among them, let me start first with the acute pericarditis. So one of the pericardial disease can be acute pericarditis. Now, what is the usual presentation of patients with acute pericarditis? The patients with acute pericarditis, they generally present with what we call as retrosternal chest pain. They present with retrosternal chest pain, just like MI. But this chest pain of acute pericarditis, unlike MI, is going to be sharp, penetrating, and it is going to be worse on inspiration. MI pain is diffuse, squeezing, non-penetrating type. It is squeezing type, right? And it is not going to have any relationship with respiration. Retrosternal chest pain, worse on inspiration. Now, the most common cause for this acute pericarditis is the question, right? What is the most common cause for acute pericarditis? It is idiopathic followed by viral infections. Most common cause is idiopathic. Now, when these patients present to us, when we examine what examination findings we are going to get in an acute pericarditis, the most important examination finding that we are going to get in acute pericarditis is the two layers of the pericardium are inflamed and they rub against each other. And their rubbing against each other produces a rubbing noise, which we call it as pericardial friction rub, or in simple words, pericardial rub. So I'm expecting to get this so-called pericardial rub or pericardial friction rub on examination. So if someone presents with retrosternal chest pain, which is worse on inspiration, and there is a pericardial friction rub on auscultation, we consider that this is possibly a case of acute pericarditis. Now for confirmation, I have to investigate, right? So what is the investigation of choice? The investigation of choice is going to be ECG. And what are the findings we are going to get in ECG? In ECG, there are 3 segments. One is PR segment, another one is ST segment, and the third one is TP segment. All the segments in acute pericarditis are disturbed. None of them are normal, right? So what are the changes that are happening? We will have depression of the... Just give me 1 second, guys. I'm not able to see your comments. Just give me 1 second. Okay, cool. Okay, just let me know in thumbs up if you are able to hear me loud and clear. Just let me know in comments if you are able to hear me loud and clear. Okay, good. So ECG, what are the findings we are going to get on the ECG? The first finding that we are going to get on the ECG is PR segment depression. We will have depression of the PR segment. We will have number 2, concave ST segment elevation. ST segment elevation is usually convex in case of MI, but here it is concave. And the third finding we are going to get is downsloping TP segment. The downsloping TP segment is also called as Spodek sign. It is called as Spodek sign. So what are the findings I'm expecting here? If this is how the normal ECG looks like, this is how the normal ECG looks like. The changes here is the PR segment gets depressed. There will be a depressed PR segment and a concavely elevated ST segment, and then TP segment starts on line but goes downwards, right? So as you see here, PR is depressed, ST is elevated but concave it is, and there is a downsloping TP segment which I have also called as Spodek sign, as I just told you. So this is the ECG finding that we are going to get. In case of MI, we will generally have convex ST elevation, which is also called as tombstone sign, and in MI we may have reciprocal changes which we don't get in pericarditis. So once I've diagnosed based on these ECG findings, how am I going to manage it? Management primarily focuses on symptomatic treatment, because more than 50% cases are idiopathic, remaining are viral, so we will try to treat them symptomatically. And what is the treatment of choice or the first line management? First line management will be NSAIDs, and you can also consider giving colchicine. We may consider steroids as the second line treatment. Second line treatment is using corticosteroids if the NSAIDs and colchicine are not helping, right? That's about our acute pericarditis. Quickly summarizing again, what is it? Acute inflammation of the pericardium. When do you call it as acute? When the duration is less than 6 weeks. We call it as acute. And these patients present with retrosternal chest pain, sharp on inspiration. Examination gives pericardial friction rub. ECG shows all the 3 segments altered. PR is depressed, ST is elevated, TP is downsloping, called Spodek sign. Once you diagnose with ECG, you treat with NSAIDs and colchicine. So that is our first pericardial disease. The second one that we are going to talk about is the second pericardial disease I'm going to talk about is constrictive pericarditis, also called as CCP or chronic constrictive pericarditis. So what is this constrictive pericarditis? The term constriction is a misnomer. It's not a true term. The pericardium is not constricting the heart. It has become stiff and it is restricting the ventricular expansion during the diastole. So constrictive pericarditis is most commonly caused by, the most common cause for constrictive pericarditis in India is tuberculosis of the pericardium. TB pericarditis is the most common cause in India, but most common cause the world over, the most common cause is going to be recurrent acute pericarditis. I just told you that the pericarditis is idiopathic in most cases, so we can't solve the underlying cause, so they keep coming back again and again with acute pericarditis. And every time there is a pericardium, the pericardium may heal with fibrosis. So as more and more episodes of pericarditis happen, I will have more and more fibrosis accumulated and the pericardium becomes stiff. When it becomes stiff, it starts creating the trouble with the expansion of the ventricle because the pericardium is stiff. Then we call it as constrictive pericarditis. So in rest of the world, recurrent acute pericarditis is the most common cause for constrictive pericarditis. The single word that you need to remember about constrictive pericarditis is abrupt cessation of passive filling. Abrupt cessation of passive filling. So when I am transferring the blood from atria to ventricle, we transfer first passive filling and then active filling. As the passive filling is happening, as I'm filling the blood into the ventricle, the ventricle starts expanding and the expanding ventricle reaches the limit of pericardial stretch. It cannot stretch anymore. It halts there. So I'm abruptly stopping the passive filling. So these patients, we have to also remember that the condition affects right ventricle more than left ventricle. It affects right ventricle more than left ventricle. Why? Because right ventricle is a thin sheet of muscle. It is more easy to stop its contraction and relaxation. Left ventricle is relatively more muscular. It is difficult to stop its relaxation and contraction, right? So it affects the right ventricle more. So you tell me now what clinical features we can expect if it is affecting the right ventricle more. So if I have difficulty to fill the blood from right atrium to right ventricle, the amount of blood filled in the right ventricle is less, right? More blood stays back in the right atrium. So right atrial pressure increases. And we know whenever there is increase in right atrial pressure, I will have raised JVP, hepatomegaly, ascites, pedal edema, the typical symptoms of right heart involvement. So in terms of clinical features, these patients will have raised JVP, hepatomegaly, ascites and edema. Ascites and edema. Same things I will also get in patients with tricuspid stenosis, tricuspid regurgitation, PS, PR, anything that affects the right side. It is a standard symptom. So how will I get to know whether I'm dealing with, like in a given question, they may mention that there is raised JVP, hepatomegaly, ascites. Can I have same in cardiac tamponade? I may not get ascites and edema, but I will have raised JVP. I may have hepatomegaly because of the congestion of the liver in cardiac tamponade. Tricuspid stenosis, same symptoms. Tricuspid regurgitation, same. PS, same. PR, same. Anytime I impair the right ventricular filling, I will have standard symptoms. So in a question, how will I recognize that examiner is talking about constrictive pericarditis and not TS, not PS? Well, auscultation findings are there. So when we auscultate these patients, as the ventricle is getting filled with blood, suddenly the passive filling is stopped. And because of the inertia of motion, this ventricle which was expanding, when we halt it, suddenly it jerks. Same thing that happens with us also, right? When we are driving and all, suddenly you brake, we jerk because we were in inertia of motion. Expanding ventricle was also in inertia of motion, but when it is halted, suddenly it jerks, makes a noise. We call that noise as pericardial knock. So the auscultation finding that we had in acute pericarditis was pericardial friction rub. The auscultation finding that we are having here is pericardial knock. What is this pericardial knock? It is a diastolic sound produced due to abrupt cessation of the passive filling. Abrupt cessation of passive filling is the main problem in patients with constrictive pericarditis, right? And I just told you that there is raised JVP. JVP has different waveforms. So what all changes happen in the JVP waveforms? The JVP waveforms we are going to see here is there is impairment in the filling of the blood into the ventricle. Passive filling is stopped in between. So I have to do more active filling. During active filling, atria contracts more, A wave becomes tall. And whenever A wave is tall, we will have a steep X descent. We will have steep X descent. So on this patient's JVP, we will have a tall A wave. Along with that, a steep X descent. And along with the steep X descent, because there is passive filling happening, but for a shorter duration, it appears steep. And the passive fillings wave is Y descent. So we will have a steep Y descent. This is a very, very important point. Last two INI-CET, there were questions asking you to differentiate between cardiac tamponade and constrictive pericarditis based on the JVP. In cardiac tamponade, there is no passive filling. If no passive filling, no Y descent. In case of constrictive pericarditis, passive filling does happen, so you will have steep Y descent. And this steep Y descent is also called as, there is a name given to this, it is known as Frederick's sign. My spelling of Frederick's may be wrong, but the name is, yes, Frederick's sign. Now, if this is a problem, how will I diagnose? The investigation of choice for the constrictive pericarditis is right heart catheterization. What we do is, we put a catheter into the right heart and measure the pressure inside the right ventricle throughout the cardiac cycle. Now, I don't have time to go into an elaborate discussion, but I can tell you what exactly happens. When we do this and measure the right ventricular pressure throughout the cardiac cycle, the passive filling gets stopped abruptly, right? It creates an abnormal waveform of the right ventricular pressure, which is called as square root sign, right? We call it as isovolumetric relaxation, pressure decreases. Passive filling, it should increase, but then abruptly it stopped, so it remains plateaued, right? We call this finding as square root sign on right heart catheterization. Square root sign. With this square root sign, once it is diagnosed, I have to manage these patients. So how am I going to manage these patients? The management, because here pericardium is stiff, it is restricting ventricular filling, I have to remove it. So management is primarily pericardiectomy for all cases. But if it is TB, if TB is the cause, then we will go ahead with antitubercular treatment for 12 months, right? That's about the constrictive pericarditis. That is the second pericardial disease. Now we have one more pericardial disease, which is nothing but cardiac tamponade. Cardiac tamponade. So cardiac tamponade, I think all of you know What is cardiac tamponade? Cardiac tamponade is collection of massive amount of fluid in the pericardial space causing collapse of the right ventricle. Till right ventricle is not collapsed, we will not call it as cardiac tamponade. We will only call it as pericardial effusion. If it is blood, hemopericardium. Only when right ventricle gets collapsed, we will call it as cardiac tamponade. To cause tamponade, I need massive collection of fluid. So which can cause massive collection of fluid? It's most likely bleeding. So the most common cause for cardiac tamponade is hemopericardium, and hemopericardium happens usually because of trauma. So trauma is the most common cause for hemopericardium. Rarely other fluids can be the reason. So when that happens, the pericardial fluid causes collapse of right ventricle, and when pericardial fluid causes, this may be blood or fluid, it will cause collapse of right ventricle. And when RV gets collapsed, it cannot relax, and if it cannot relax, there is no isovolumetric relaxation. If there is no isovolumetric relaxation, passive filling is not possible. So the main thing you have to remember about the cardiac tamponade is that in cardiac tamponade, no passive filling occurs. Why passive filling cannot occur? Because there is so much fluid that has compressor collapsed the ventricle. It cannot relax. If it cannot relax, it can't receive the passive filling. So there is no passive filling. The wave of passive filling on JVP is Y descent. So in constrictive pericarditis, we had the Y descent present. Here, Y descent will be absent. So in terms of clinical features, you know that they present with what is called as Beck's triad. And what are the components of Beck's triad? You will have raised JVP. Why? Because passive filling was not possible. I have to do all the filling in active filling. Atrial pressure will be high. I will have raised JVP. And within that raised JVP, we should also know that the raised JVP includes a tall A wave. And whenever A wave is tall, we will have a steep X descent. X descent becomes steep. The problem is we will have a absent Y descent. The Y descent is prominent or steep in case of constrictive pericarditis. In cardiac tamponade, no passive filling. The wave of passive filling is Y descent, no Y descent. So second thing that we get in this patient is, after the raised JVP, we will also have hypotension. Why are we getting hypotension? If you may ask, I will say, if right ventricle is collapsed, I can't fill the blood into it sufficiently. No passive filling, only active filling, little bit of filling. So little bit of blood goes to the lung, little bit of blood comes to the left side, little bit of the left ventricular filling. So low is the stroke volume coming out of left ventricle, and stroke volume and systolic BP are directly proportionate. Low stroke volume, low systolic BP. That's why we are getting hypotension. And fluid is not a good conductor of sound. So when I try to auscultate, the heart sounds will be muffled because the fluid filters out a lot of frequencies. So we will have muffled heart sounds. We will call this as Beck's triad. Now, once I have suspected it, like someone with a road traffic accident having raised JVP, hypotension, and muffled heart sounds, Beck's triad, we suspect cardiac tamponade. For diagnosis, what is the investigation of choice for cardiac tamponade? You may say, sir, we can do an X-ray. Yes, X-ray shows a water bottle shaped heart, but that's not the investigation of choice, because X-ray only tells that there is collection of fluid. It doesn't tell you collapsed right ventricle. What is the investigation of choice? The investigation of choice is going to be echocardiography. So there you can see, in the echocardiography, you can see a collapsed right ventricle pericardial fluid. Okay, I forgot to write. Investigation of choice is going to be echocardiography, and on the echocardiography, you will be getting collapsed right ventricle pericardial fluid, and if you are able to view, you will be also seeing dilated inferior vena cava, dilated IVC. These findings are also called as echo triad. Beck's triad is clinical triad, and these three things, collapsed RV, pericardial fluid, and dilated IVC, is the echo triad of cardiac tamponade. Now, ECG is not the preferred investigation, but if you have done ECG, what finding you are going to get? Heart inside the ventricle, heart inside the pericardial space will be moving like a pendulum, because there is so much of fluid, right? Inside the fluid, it is moving like a pendulum, and this pendular movement makes the heart come closer to the surface of the chest, go away. So when it comes closer to the surface of chest, the QRS voltage recorded will be high. When it is away, the QRS voltage recorded will be low. It produces what is called as electrical alternance. electrical alternance. Please don't get confused with electrical alternance with pulsus alternance. Pulsus alternance is seen in patients with the left ventricular failure, LVF or heart failure, where pulse amplitude in alternatively becomes high and low. Here, QRS voltage is becoming alternatively high and low. So you will have one QRS voltage which is high voltage, then you will have another QRS voltage which is low voltage. Then again next one will be high voltage. So you will have an alternate high and low QRS voltage. This phenomenon is what we are calling as electrical alternance. Once I have diagnosed cardiac tamponade, how will I manage? There is a two-step or three-step management process. First thing is there is too much of fluid. It has caused hypotension. So I have to remove the fluid. So the management will be emergency pericardiocentesis. It will be emergency pericardiocentesis. Now many books or many other teachers might say that we go for thoracotomy, but the truth is thoracotomy is a planned procedure. Emergency may not happen always. So best thing is remove the fluid first so that you make sure that the patient is hemodynamically stabilized. After that, once you have a time and flexibility, take the patient to the surgery room and in the operation theater and explore and find out which blood vessel is bleeding and ligate it. So emergency pericardiocentesis is the immediate step, followed by you can do explorative thoracotomy to identify where is the bleeding happening, and then you can treat accordingly, right? So key points, the kind of questions asked nowadays are differentiating between cardiac tamponade and constrictive pericarditis. What are the key points that will help you to differentiate? Both of them have raised JVP, both of them can have hypotension. The main differentiating feature is muffled heart sounds in patients with cardiac tamponade and absent Y descent on JVP. Here on auscultation, we are getting what is called as pericardial knock. There muffled heart sound, here pericardial knock. There absent Y descent, here steep Y descent, right? These points are going to help us to differentiate. So that completes our pericardial diseases. After the pericardial disease, the next cardiac disease that we're going to talk about is the disease of the cardiac muscle. We covered the pericardium, three major: acute, constrictive, and cardiac tamponade done. Now we will look at the myocardial diseases. After that, we will look at the valvular heart diseases. What are the myocardial diseases that we know? Yes, we have something called as cardiomyopathies. So can anybody tell me what do you mean by cardiomyopathies? What do you mean by cardiomyopathies? The cardiomyopathies refer to diseases of the cardiac muscle in the absence of hypertension, valvular heart disease, and ischemia. So next we are going to talk about is cardiomyopathies. Cardiomyopathies. These are disorders of the myocardium. Disorders of the myocardium. In the absence of, because myocardium can get altered when you have valvular heart disease. It can get altered when you have like hypertension. It is altered, it is dead or infarcted in case of ischemic heart disease. But in the absence of, these are diseases of myocardium in the absence of hypertension, ischemic heart disease, valvular heart disease. Then we call them as cardiomyopathies. And as you know, cardiomyopathies are classified into dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. So what is this dilated cardiomyopathy? Normally a chamber dilates when its pressure increases according to Boyle's law. But a chamber, if like ventricle, if it dilates without a reason, then we will call it as dilated cardiomyopathy. How do I define it? Left ventricular end diastolic diameter more than 6 centimeter in the absence of hypertension, IHD, valvular heart disease. The most common cause for dilatation of the left ventricle is IHD. But once IHD is ruled out, then we think of dilated cardiomyopathy. So the first question they will ask is, what is the most common cause? So in dilated cardiomyopathy, the left ventricle becomes dilated than usual. So the left ventricle is dilated. Dilated left ventricle. The most common cause for that is a toxin which most of you may be taking, and that is alcohol. The other causes include cocaine, drugs like the trastuzumab, pertuzumab, adriamycin, doxorubicin, daunorubicin. These are the drugs. But the question that they will ask is, what is the most common cause for familial dilated cardiomyopathy? Most common cause is alcohol. But if it is inherited, what is the most common cause? Most common cause for familial dilated cardiomyopathy. Familial dilated cardiomyopathy. There are plenty of mutations. The most common mutation that is responsible for the familial dilated cardiomyopathy is mutation in titin gene. Mutation in titin gene. Other causes include drugs. Mainly, if I'm talking about drugs, cocaine is also a drug. Apart from that, adriamycin, doxorubicin, daunorubicin, trastuzumab, and pertuzumab. These are all the drugs for dilated cardiomyopathy. Postpartum or peripartum cardiomyopathy is also a form of dilated cardiomyopathy. I will leave it to the OPG faculty to address about it. Now, in terms of clinical features, they present with features similar to heart failure with reduced ejection fraction, because here the dilatation is because of the atrophy of the left ventricular muscle mass. So if it is atrophied, it cannot generate sufficient force of contraction to eject the blood. So ejection fraction will be down. We will have heart failure with reduced ejection fraction. And when it comes to management, how are we going to manage these patients? The management will primarily focus on treating the underlying cause, treat underlying cause, and if underlying cause is not treatable or it's not sufficient, then standard heart failure treatment. What is the standard heart failure treatment? AC inhibitors, ARBs, beta blockers, SGLT2 inhibitors. And if the EF is very low, you may consider giving angiotensin receptor plus neprilysin inhibitors, right? So important MCQ points on dilated cardiomyopathy. Left ventricle dilates without a valvular cause for its dilatation. Commonly, it can dilate in AR, it can dilate in MR, but without a valvular lesion, left ventricle is dilating. Most common cause is alcohol, most common familial cause is titin mutation. The rest of the things are not that important, they're unlikely to be asked. The next one is restrictive cardiomyopathy. So restrictive cardiomyopathy, there is restriction to the ventricular filling. So in dilated cardiomyopathy, ventricle is dilated, it is failing to eject the blood. So it is primarily a systolic dysfunction. In dilated cardiomyopathy, what we have is systolic dysfunction because ventricle is atrophied. Systolic dysfunction. During systole, I can't eject. That's why my ejection fraction is going to be reduced. But restrictive cardiomyopathy is a form of diastolic dysfunction. Means there is restriction to the relaxation of the ventricle. So it can't receive blood. So it is a problem in diastole. It's a diastolic dysfunction. Now what can make my ventricle not receive blood or not relax easily? Not talking about the valve or pericardial disease, because if something else is causing, we will label them accordingly. Like if pericardium is restricting, it is constrictive pericarditis. If fluid is restricting, it is cardiac tamponade or pericardial effusion. Then what can restrict? Muscle itself is getting restricted because it has loaded with abnormal substances. So the common causes for there is restriction to ventricular filling. Restriction to ventricular filling. And why is there a restriction here? Because the muscle is stiff, unable to relax. Now tell me which ventricle is most likely to get affected here. The ventricle that is most likely to get affected here is going to be yes, the ventricle that is most likely getting affected is, it affects right ventricle because it's more easy for me to stop relaxation and contraction of a thin muscle than a bulky muscle. So right ventricle is thin muscle than left. So it affects right ventricle more than left ventricle. So what symptoms do we expect? Same that we got in constrictive pericarditis and cardiac tamponade, raised JVP, hepatomegaly, ascites, pedal edema. How will I differentiate? Yes, I have to rule out pericardial diseases. I have to rule out right-sided valvular disease before I label it as restrictive cardiomyopathy. So clinical features are going to be standard right-sided symptoms, that is raised JVP, ascites, hepatomegaly, edema. Hepatomegaly, edema. If you ask me what can cause this, the causes are mainly storage disorders. If I store abnormal substances in the cardiac muscle, it may not be able to relax well during the diastole and I will have filling defect. Storage disorders. I'm not going to make a list of them. Biochemistry sir would have given you a list of storage disorders that are associated with restrictive cardiomyopathy. I can just quote few examples. Amyloidosis, hemochromatosis, von Jurke's, Pompe's disease, lot of glycogen storage disorders, lipid storage disorders, they can present with cardiomyopathies. Okay. So when it comes to their management is treating the underlying cause. Like if I have hemochromatosis, I have to bring down the iron level because iron is being stored in the cardiac myocyte. It is not able to relax. If I remove it, it will settle. So treating the underlying cause is the option. So dilated cardiomyopathy is a left heart disease causing systolic dysfunction. Restrictive cardiomyopathy is a right heart disease causing diastolic dysfunction. Next one is our hypertrophic cardiomyopathy. This is the single most important chapter from cardiomyopathies, from where maximum number of MCQs are asked from the cardiomyopathy. So what you need to know from the hypertrophic cardiomyopathy? It is a purely inherited disorder. It is inherited. The restrictive cardiomyopathy or dilated can be acquired. If you drink regularly, you will have dilated cardiomyopathy. If you load iron or if you develop any of these amyloidosis, you can acquire the restrictive cardiomyopathy. But hypertrophic cardiomyopathy cannot be acquired. It is inherited. It is very, very common. It affects 1 in 500 births and it is due to mutation in beta myosin heavy chain gene. This is an MCQ asked already. Beta myosin heavy chain gene. Now what happens here? Usually hypertrophy happens when a muscle does extra work. Either preload or afterload should be increased. But here, without any increased preload or afterload, muscle start developing hypertrophy. That's why we're calling it as hypertrophic cardiomyopathy. It mainly causes left ventricular hypertrophy. But that's not the problem. The main problem is along with left ventricular hypertrophy, it causes what is called as asymmetric septal hypertrophy. Asymmetric septal hypertrophy. Asymmetric septal hypertrophy. So exactly what is happening here? Your left ventricle, like let us say this is the left side of the heart that we are looking at, and this is the left ventricle, this is aorta, this is left atrium that we are looking at. Now, the area of the ventricle where the blood moves from the aorta, from the atria into this ventricle is called as left ventricular inflow tract. This area where the blood is moving into it is called as left ventricular inflow tract because blood comes into LV through this. And the portion of the left ventricle from where the blood moves out of the left ventricle, this area is called as left ventricular outflow tract. Left ventricular outflow tract. So in these patients, I develop this concentric type of left ventricular hypertrophy. And that's not a big deal. What is the big problem? This septum, interventricular septum, becomes asymmetrically hypertrophied. It's not symmetrically hypertrophied. It is eating into the left ventricular outflow tract space. So if it becomes more and more hypertrophied, one day it will start causing the obstruction to the flow of blood. And when it causes obstruction, we will call it as hypertrophic obstructive cardiomyopathy. So this asymmetric septal hypertrophy may cause left ventricular outflow tract obstruction, and when it is causing obstruction, then we will call it as hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. So HCM and HOCM are not different diseases, just a spectrum of the same disease. Okay. Extra point that you need to know about this is obstruction is not the only problem. So when it causes obstruction, the obstruction is also known as subvalvular aortic stenosis. The obstruction is also known as subvalvular aortic stenosis. Why? Because aortic stenosis obstruction is in the aortic valve, but here just underneath it, this area is creating the obstruction. So we will call it as subvalvular aortic stenosis. AS, subvalvular AS. So these patients, for the So that's not just the obstruction which is problem. Many patients may not develop obstruction, they remain asymptomatic. But the problem is this alteration in the structure of ventricular muscle cell increase the risk of developing VT/VF, and these patients can have sudden cardiac death. In fact, hypertrophic cardiomyopathy is the most common cause for sudden cardiac death in young individuals and athletes. Young individuals and athletes. Overall, if you ask me what is the most common cause of sudden cardiac death, it is ischemic heart disease. But in young and athletes, it is going to be hypertrophic cardiomyopathy. So that means being an inherited, very common disease, ideally all individuals should be screened. In India, we don't practice that, but at least athletes, young individuals who are sports enthusiasts should be screened. And when I'm screening for diagnosis, what will be my investigation of choice? Echo will be considered as the investigation of choice. And in the echo, what are the findings we are going to get? We have already learned about the finding. One of them is going to be left ventricular hypertrophy that we see here. Second thing we are going to see is asymmetric septal hypertrophy. This is usually abbreviated as ASH. The third thing we notice is on this interventricular septum, we have a papillary muscle whose chordae is attached to anterior mitral leaflet. So when this interventricular septum becomes hypertrophic, strong, right? During systole, it generates a strong pull. So these papillary muscles will pull the anterior mitral leaflet strongly to descend down. This descending down is called as anterior motion of anterior mitral leaflet, or SAM, because it moves in systole. Plus, the plus finding we are going to get is systolic anterior motion of anterior mitral leaflet. This is usually abbreviated as SAM. A very, very important clue. Any question that talks about SAM is talking about hypertrophic cardiomyopathy. Clear? So when these findings are there, we make a diagnosis. And also, I want to tell you that when I have caused this concentric hypertrophy, the left ventricle becomes small. So to fill the blood into it becomes difficult. I can't fill sufficient blood because the cavity is small, right? So it causes diastolic dysfunction. So this LVH is also known to cause, because this is concentric LVH, not eccentric LVH, it is known to cause diastolic dysfunction. There will be difficulty to fill blood into the small ventricle. It will cause diastolic dysfunction. All these are important MCQ points. What is the main pathology? We end up with diastolic dysfunction. But what is the main concern? There is high risk of death because of developing VT and VF. The mechanism for this death is developing ventricular tachycardia or ventricular fibrillation. So if I have to treat, the management should cover treating obstruction if there is an obstructive symptom, HOCM, and treating the risk of sudden cardiac death. So how do I treat the risk of sudden cardiac death? To decrease sudden cardiac death risk, what we can offer them? We can give them beta blockers. Beta blockers minimize the chance of developing VT/VF. And if it happens or risk is high, we go ahead with implantable cardioverter defibrillator, right? And to decrease obstructive symptoms, HOCM symptoms, what should I do? The interventricular septum, which is asymmetrically hypertrophied, is creating the obstruction. We can cut this off. When we cut this off, it is called a septal myomectomy. Or I can inject alcohol into it, it will become atrophied. So one of them can be followed. So we can either do what we call as septal myomectomy or alcoholic ablation. Septal myomectomy or alcoholic ablation. So that completes our cardiomyopathies or myocardial disease. So far we have discussed the pericardial diseases. We have discussed the myocardial diseases. Now what is pending in cardiology? We have valvular heart diseases. And then in heart, we also have a conduction system, SA node, AV node. From the conduction system, arrhythmias and AV blocks are asked. So today I will address the AV blocks. So next topic we are going to discuss is AV blocks. So there are AV blocks. When we say, it refers to AV nodes function being affected. So what is the function of AV node? AV node's main function is to receive the electrical impulse from the SA node and then deliver it to the ventricle. But delivery is not the only function. It should also do a necessary delay. So AV node is supposed to do a necessary delay. So AV node receives the signal from the SA node and then does AV nodal delay to give you PR segment and then passes it down to the ventricle. If it fails to conduct to the ventricle, it's AV block. Or if it does unnecessary delay, then also it is called as AV block. So there are three grades of AV block. The first grade AV block or first degree AV block is where the delay is unnecessary. There is no deficit in conducting. Every time impulse comes, it conducts. So what is the ECG finding that we are going to get here? In the first degree AV block, you will have prolonged PR interval. You will have prolonged PR interval because AV nodal delay is increased. AV nodal delay is assessed by PR interval. What is the normal PR interval? The normal PR interval is 120 to 200 milliseconds. That means in an ECG, your P to the QRS complex beginning should be accommodated within one small box is 40 milliseconds. So within 3 to 5 small boxes. Less than 3 is short PR interval, more than 5 is prolonged PR interval. So in the first degree AV block, there will be prolonged PR interval. But because there is no conduction failure, there will be no missed QRS. Only unnecessary AV nodal delay. But every time it does delay but gives the signal to the ventricle, so there will be a QRS. Every P will be followed by a QRS, but PR will be delayed. So when I look at this ECG, we notice that every P is followed by a QRS. There is no missed QRS. But when I look at the PR interval, the PR interval here appears to be prolonged because it is taking almost 2 large boxes or 9 small boxes. 2 large boxes means 1 is 5. So total 10 small boxes, 1 is 40 milliseconds. 1 small box is 40 milliseconds. So how much is the PR interval here? If you count 9, it is 360. If you count, I am counting 9, so it is 360 milliseconds. Normal is 120 to 200. It is definitely more than that. So this is first degree AV block. But in the second degree AV block, AV node intermittently fails to conduct the signal to ventricle. So we will start seeing missed QRS. And when I have missed QRS, it could be two subtypes of second degree AV block. Second degree AV block Mobitz type 1 or 𝐌𝐞𝐝 and second degree AV block Mobitz type 2. So what do we get in Mobitz type 1? In Mobitz type 1, we will have serial prolongation of PR interval. Prolongation of PR interval. Why? Because the AV node is increasing its delay. AV nodal delay goes on increasing till a point where AV node fails to conduct the impulse to the ventricle, and then I will have a missed QRS. So we will have a intermittently missed QRS. But then we also have this one more type called as Mobitz type 2. In Mobitz type 2 also, intermittently AV node fails to conduct the signal to ventricle. So we will have intermittently missed QRS. But what you notice is the PR interval is constant. This constant PR interval may be normal or increased, but it is constant. It is not increasing from beat to beat. Now let us look at this ECG. In these two ECGs, you can notice that there are missed QRS. There was supposed to be a QRS here because there is a P behind it, but QRS is not seen. Here also supposed to be a QRS, but it is missed. So whenever we have missed QRS, we are thinking about second degree AV block. In first degree, there is no missed QRS. Right? So that's why if there is an MCQ about AV block, what is the first thing I should see in the ECG? Okay, you may ask me, sir, what is the first thing I should see in the ECG first of all, right? Remember, ECG in the exam should be read by first looking at the options. If there is a question opening in front of you which has an ECG image, first thing you should see is read the options. Once you read the option, you already know what examiner is looking for here. If the option says first degree AV block, second degree Mobitz type 1, second degree Mobitz type 2, complete heart block, then you know the question is about AV blocks. Then approach the ECG accordingly. If the option is inferior wall MI, lateral wall MI, anterior wall MI, then the examiner wants to know whether you can detect different types of MI. So then approach accordingly. Like I should see ST segment. But here what I should see, any question of AV block, first thing you should see is whether there is missed QRS present or not. If missed QRS is present, it is second degree AV block. If no missed QRS, it could be first degree. Check the PR interval. If that is prolonged, yes, then it is first degree. If no missed QRS, no prolonged PR interval, then there is no AV block at all. As simple as that. Once I encounter missed QRS, I should see, first thing I should see is missed QRS. If I have missed QRS, behind that I should see what is happening to the PR interval. If PR interval appears to be serially increasing till a QRS get missed, then it is Mobitz type 1. As you see here, if I label the PR interval, you can clearly see that it was serially prolonging. Here it is taking 6 small boxes. That means it is 240 milliseconds. And then here it is taking 7 small boxes. That means 280 milliseconds. Here it is taking almost, I can say, 9 small boxes. That is 360 milliseconds. So the PR interval serially went on prolonging till it got missed. Then it is Mobitz type 1 or 𝐌𝐞𝐝. In the second ECG also there is a missed QRS, but when I look behind this, all the PR intervals appear constant, right? This is same, this is same. There is no variation in the PR interval. Then we will call it as Mobitz type 2. Okay, the second degree can also be expressed in terms of ratios, like how many P's are there for how many QRS. Like you see here, 1 P, 1 QRS, 1 P, no QRS, another P, QRS present, P, no QRS, P, QRS present. Here, every second P wave has failed to conduct into the ventricle. So if I look at the ratio, for every 2 P waves, there is 1 QRS, right? Every 2 P waves, there is 1 QRS. So then I can say 2:1. If it is expressible in ratio, you can express. If not, just call it as second degree Mobitz type 2 heart block. Then we have the so-called third degree or complete AV block. What happens in complete AV block? In complete AV block, the AV node is completely blocked. It fails to conduct. No impulse is being conducted down to the ventricle. In that case, what happens? The moment I completely block it, a new pacemaker emerges below the ventricle. Below the AV node. It could be at the junction or his bundle branches or Purkinje fibers. So when there is absolute AV block, we will have two pacemakers in the heart. One SA node for the atria, whose rate is 60 to 100 per minute. SA node keeps firing at 60 to 100 per minute. That's our heart rate is 60 to 100. But the new pacemaker that is formed below will not be able to give you that rate. So ventricular rate will become less. Atrial rate will be more. Because like if his bundle AV node spacing rate is 50 to 60, his bundle is 25 to 40. Purkinje fibers is also same 25 to 40. So the ventricular rate will be 25 to 40, atrial rate will be 60 to 100. Then we will call it as complete heart block. So in that case, what will happen? The resultant ECG will show high atrial rate, low ventricular rate. And now because they are beating at different rates, the normal observation of P followed by QRS will not be seen. P appears haphazardly or randomly in the ECG. QRS appears randomly, P appears randomly. In other ECGs, except the missed QRS, every time a P was followed by a QRS, except the missed. Always P comes before the QRS, right? Q always comes after the QRS. But here, you will notice that P appears randomly without a relationship with the QRS. So as you see here, sometimes this P is coming before QRS, sometimes right along with the QRS, sometimes after T wave, sometimes after T wave, sometimes before QRS. So this relationship of P followed by QRS is distorted. Then we will call it as complete heart block or third degree AV block. If you want, you can calculate the ventricular and atrial rate. How will I calculate? Ventricular rate is calculated by 300 divided by number of large boxes between two R waves. And atrial rate is calculated by 300 divided by number of large boxes between two P waves. So if you want to calculate here, we can calculate. I will just give you a quick hints up. Let us say what is the atrial rate here. So if I want to calculate the atrial rate, how can I calculate in this ECG? Atrial rate here is 300 divided by number of large boxes between PP interval. So how much it will turn out to be? As you see here, 1, 2, 3, half this side, so I can count it as 4. So 300 divided by 4 is 75. But what about ventricular rate? Which pacing structure has a rate of 60 to 100? SA node. So it means atrial pacemaker is, pacemaker for atria in this patient is SA node. Let us see what is the pacemaker for the ventricle. Ventricular rate is 300 divided by RR, number of large boxes between RR. So 1, 2, 3, 4, 5, 6, and I can say 7. So 300 divided by 7. 300 divided by number of large boxes between RR interval. So in this case, it will be 300 divided by 7. I don't know the exact number. I can guess it is around 42 something, approximately 40. So in that case, what could be the pacemaker? Can this be SA node? No. Can this be AV node? No. Something below the AV node, right? Maybe at the junction of the AV node and the His bundle, or maybe His bundle, but certainly not the SA node or AV node. So pacemaker could be the junction, or could be the His bundle, or could be bundle branches, or it could be Purkinje fibers, whose rate is usually close to this 40 value. So we can prove that AV node is completely blocked, and that's why we have 2 pacemakers, right? That is our complete heart block. Easy here. You don't have to bother so much. If it is a question of AV blocks, and if it does not fit into first degree and second degree Mobius type 1, Mobius type 2, which you can easily recognize, it's not fitting into it, label it as third degree AV block or complete heart block. Now the question is, all these patients, if I have to manage, how do I manage? Management of AV blocks. So remember, when we are managing AV blocks, the first degree is usually asymptomatic. First degree, all we have to do is reassurance. And then second degree Mobitz type 1, we don't need to always treat them, but second degree Mobitz type 2 and complete heart block or third degree block should always be treated. Mobitz type 2 and complete heart block, which is also called as third degree AV block. These treat if symptomatic. But if it is Mobitz type 2 or complete heart block, they are always treated. So when I have to treat, right, what is the treatment? So first line treatment is going to be IV atropine. IV atropine can be considered as the drug of choice for the heart blocks. But atropine we cannot give long time. So if there is no solution for underlying block, why there is block? It could be because of drugs, it could be because of MI. If I'm not able to treat underlying cause, then I have to go for second line, which can also be considered as the definitive treatment. And that is going to be pacemaker insertion. So pacemaker or pacing will be the definitive treatment, but the initial drug of choice is going to be atropine. Clear? So that completed our discussion on the AV blocks. So in cardiology, we have addressed the 3 major topics. Only other major topic we have is valvular heart disease, which I have done a Telegram session with a detailed quick approach to valvular heart disease. It will take 10-15 minutes. Go through that as well, so that you can deal with the valvular heart disease questions also. Now I will migrate to neurology. Now inside the neurology, what are the important diseases? Inside the neurology, the important diseases are myasthenia gravis, GB syndrome, multiple sclerosis, amyotrophic lateral sclerosis. These are the 4 important diseases. We will address them. So first we'll start with the myasthenia gravis. What is myasthenia gravis? Myasthenia gravis is a neuromuscular junction disorder. It's a neuromuscular junction disorder. What type of neuromuscular junction disorder? It's a postsynaptic neuromuscular junction disorder. Here, it's a postsynaptic neuromuscular junction disorder. It is an autoimmune disorder, so we have antibodies against. There are 3 types of antibodies. Notice the first one is anti-acetylcholine receptor antibody. This is the most common antibody, followed by anti-muscle specific kinase antibody, followed by anti-lipoprotein 4 receptor antibody. So this anti-acetylcholine receptor antibody is the most common antibody. Anti-musk is the second most common. Anti-lipoprotein 4 receptor antibody is the least common. Why should I know the antibody status? Because thymectomy is one of the procedures that is done for treatment of myasthenia gravis. It is only useful for anti-acetylcholine receptor antibody positive patients, not for anti-musk and anti-LP4. So thymectomy is useful for these patients. Thymectomy is not useful for the other patients. Okay, clear? Now, being an autoimmune disorder, it is more common in females than males with a ratio of 4:1. Now, what is the most common presenting feature of these patients? These patients present with ptosis. That's the typical feature. So they can have ptosis, diplopia, proximal muscle weakness, means proximal muscles, the shoulder girdle, hip girdle, arm and thigh muscles can become weak, proximal muscle weakness. And apart from that, rarely they can also have respiratory weakness, proximal muscle weakness and facial weakness, facial muscle weakness. Rarely they can have respiratory. Distal muscles are not usually affected. If a patient of myasthenia gravis presents to you with only ptosis and diplopia, then we will call it as ocular myasthenia gravis. This is called as ocular myasthenia gravis. But if the patient has ptosis plus other symptoms, then we will call it as generalized myasthenia gravis. Only point I want you to remember here is if there is ocular myasthenia gravis, the general recommendation is, because diplopia and ptosis can happen because of cranial nerve palsy by compression of the tumors in the brain, midbrain and all. We have to do a CT or MRI of the brain to rule out those causes before we conclude it as myasthenia gravis. Right? So it needs CT or MRI brain to rule out compressive causes for cranial nerve palsies. If it is generalized myasthenia gravis, I won't be thinking about tumors. It's a very classical story, so we'll follow that. Another point I want you to remember is that all these symptoms that we are talking about, these symptoms have what we call as diurnal variation. They have diurnal variation. The weakness worsens as the day progresses. In Lambert-Eaton, the weakness improves as the day progresses. So when someone comes with these symptoms, ptosis, diplopia, proximal muscle weakness, facial weakness, I forgot to address. This facial weakness also produces a peculiar facial appearance when we ask the patient to smile, which is now called as myasthenic smile. Once upon a time, it is called as snarling faces. So when we ask them to smile, this can be image-based question as well. The patient will have ptosis, and when you ask them to smile, they can't lift the lateral edge of the mouth up. A good smile is lateral edge of the mouth lifted up. They can't because these muscles are weak or drooped. So only lip philtrum gets lifted up or mid portion gets lifted, revealing teeth. It resembles a dog trying to show the teeth. That's why it is called as snarling faces, or it is also called as myasthenic smile. Myasthenic smile. These are the clinical features. So if I am suspecting myasthenia gravis, I have to investigate. So when it comes to the investigations, the investigation of choice currently is not hydrophonium test. What is the investigation of choice? The single fiber electromyography, where we will repetitively stimulate the muscle to see its force of contraction or action potential. In myasthenia gravis, repetitive stimulation keeps the first force of contraction go on decreasing, or the muscle contraction progressively starts becoming more and more jittery instead of being a full contraction. We describe it as increasing jitteriness, or we will also call it as decremental response. In Lambert-Eaton syndrome, we get incremental response. In Lambert-Eaton, we get incremental response. Here, we get decremental response. Other investigation that we can do is, we can do an ICE-PAC test. ICE-PAC test is considered as the bedside screening test of choice. This is the bedside screening test of choice, where ptosis improves on applying ICE-PAC. It shows ptosis improves on applying ICE-PAC. Then it is called as ICE-PAC test positive screening test. It's a good screening test. Okay. Apart from that, I forgot to mention, this single fiber electromyography is the most sensitive investigation for myasthenia gravis. They may also ask you what is the most specific investigation. The most specific investigation is finding anti-acetylcholine receptor antibody. Anti-acetylcholine acetylcholine receptor antibody positivity is the most specific investigation. Last but not the least, why edrophonium test is not done. In edrophonium test, we administer edrophonium or tensilon, which is an acetylcholine esterase inhibitor. It increases the acetylcholine not only in the neuromuscular junction of the skeletal muscles, but also in the glands and smooth muscles. So it increases the contraction of other smooth muscles, and it will also lead to increased secretion of the glands, what is called as cholinergic crisis. This is avoided due to risk of what we call as cholinergic crisis. Cholinergic crisis. So multiple MCQs possible from investigation. What is the investigation of choice? It is single fiber electromyography. What does it show? Decremental response on repetitive stimulation. This is the most sensitive investigation. Most specific is anti-acetylcholine receptor antibody. Edrophonium is not performed routinely due to risk of cholinergic crisis. Okay, upon investigation, now the time is how do I manage these patients? Here, there is a competitive inhibition of the acetylcholine receptors by the antibodies. So I have to now make acetylcholine win. So I have to increase acetylcholine, decrease antibodies. So how can I increase the acetylcholine? To increase acetylcholine, we will use acetylcholine esterase inhibitors. And the drug of choice acetylcholine esterase inhibitor is pyridostigmine, because it is long acting and does not cross the blood-brain barrier efficiently. So I wanted more acetylcholine in the skeletal muscle. It gives me more acetylcholine in the skeletal muscle without disturbing my acetylcholine action in the brain. That's why pyridostigmine is a drug of choice, and it is long acting. I don't have to administer repeated doses. Now, to decrease antibodies, what should I do? To decrease antibodies, we can consider immunosuppressants or steroids. Another thing I can do to decrease the antibodies is to get rid of the thymus gland, because the antigen for this myasthenia gravis is myoepithelial cell of the thymus gland. That's why removing the thymus gland gets rid of the antigen. If no antigen, no antibody, right? So we may consider thymectomy if it's not for all patients. If it is a case of anti-acetylcholine receptor antibody positive case, aged less than 50 years. Some books mention 55 years, because we want to also make sure that it is done in a safe individual, not in an elderly where the procedure is risky, right? Clear? Now, some of these patients may develop what is called as myasthenic crisis. What is myasthenic crisis? Respiratory failure. Myasthenic crisis refers to myasthenia gravis leading to respiratory failure. Myasthenia gravis leading to respiratory failure. Rare, but it can happen. So when that happens, what is the treatment of choice? Here, antibodies are too high. So I have to quickly bring down the antibodies. So quick bringing down of the antibodies is possible when I give them IVIG or plasma exchange. IVIG will neutralize the antibodies, or plasma exchange will help us get rid of the antibodies from the body outside. This is about our myasthenia gravis. So important MCQ points we have already dealt. Now we will go to the next important topic, which is GB syndrome. GB syndrome. So what is this GB syndrome? Myasthenia gravis was a neuromuscular junction disorder. What is this GB syndrome? This GB syndrome is a peripheral nerve disorder. It's a infection triggered polyneuropathy. It's a infection triggered. Infection is not the cause for the nerve damage. It is only triggering your immune system. Your immune system is causing the damage. Infection triggered polyneuropathy. Yes. Can I count it as an autoimmune disorder? Yes. Infection is triggering the autoimmune action. So it is an autoimmune disorder. Or you can also call it as autoinflammatory. So if infection is a trigger, they will ask you what is the most common trigger. Most common infection is going to be GIT infection, mainly Campylobacter jejuni. Campylobacter jejuni. And what are the other triggers that can cause? The other triggers for immune system to get activated include number one, viral infections and vaccines. So some of the vaccines are also known to trigger GB syndrome. Okay, clear? Now, what is the clinical feature that these patients are going to present with? Whenever polyneuropathy happens, length-based involvement, longest neurons get affected first. Longest neurons are going from lumbar segments of the spinal cord to the feet. So that is where you will start seeing the weakness. And then the next longest to the leg. Then next longest. So you will get this classical ascending paralysis. And in the peripheral nerves, we have lower motor neurons. So ascending paralysis will be associated with LMN findings. That is decreased tone, decreased reflexes. So patients will present with rapidly progressing ascending paralysis, and I want you to remember one extra point. When the ascending paralysis is progressing, the progression lasts for less than 4 weeks. It does not continue beyond 4 weeks. It's like, okay, 5th week, 6th week, it's still progressing, doesn't happen. So progression lasts for less than 4 weeks. Less than 4 weeks. Along with that, because lower motor neuron is affected, you will have flaccidity or hypotonia. Plus, you will have hyporeflexia or absent reflexes, areflexia. Classical lower motor neuron findings. You can simply call it as flaccid ascending paralysis with hyporeflexia or areflexia. So when someone comes with these symptoms, especially following a Campylobacter jejuni dysentery, I have to diagnose, right? So how will I diagnose these patients? For diagnosis, we are following a criteria which is called as Brighton's criteria. So what this Brighton's criteria says is, for diagnosis, you need 3 clinical parameters. The first one is ascending paralysis, which is rapidly progressing. Progression lasting for less than 4 weeks. If it lasts more than 4 weeks, it is suggestive of a chronic condition called as CIDP. Second, there should be flaccidity or hypotonia. Third, there should be hypo or areflexia. Along with that, I will take help of the lab. So lab are 2 investigations we can do. One of them is CSF analysis. And the second one is neuroconduction studies. So neuroconduction study may show the evidence of either damage to axon, axonal injury, or damage to myelin, called as demyelination. Axonal injury or demyelination on neuroconduction study. What CSF shows, here antibodies are causing the damage to the nerves. So antibodies will be increased in CSF as well. And antibodies are what? Protein. So CSF protein will be high, cell count will not be increased much. This condition we will call it as albuminocytological dissociation. Albumin and protein generally both increase. If I have viral meningitis, bacterial meningitis, albumin, protein both increase. Means protein and cells both increase. Here only protein is increased, cell is not increased. That's why we are calling it as albuminocytological dissociation. So we'll have increased protein and relatively normal cell count. It may be slightly elevated up to 50 we may see, but close to normal only. But protein can be grossly elevated. So this phenomenon we call it as albuminocytological dissociation. Albuminocytological dissociation. A lot of MCQs mention this. The moment you hear this, you know examiner is talking about the GB syndrome. Though it is seen in other conditions also, for the exam, it's always about GB syndrome. So when these criteria are met, we will call it as GB syndrome. Now, we will also have some classification of GB syndrome to understand before we talk about the management. And when it comes to classification, it is based on the neuroconduction study. Based on neuroconduction study findings. Neuroconduction study tells whether there is axonal injury or demyelination. So based on that, we have one type called as AIDP. It stands for acute inflammatory demyelinating polyneuropathy. It's there in the name. It's a demyelination type. Then we have 2 more types called as AMAN, acute motor axonal neuropathy. That means injuries to the axon. Another is AMSAN, acute motor and sensory axonal neuropathy. That means both motor and sensory are affected. And then we have one more variant called as Miller-Fisher syndrome. Miller-Fisher syndrome. My spelling may be wrong of the Fisher, but the pronunciation is Fisher, Miller-Fisher syndrome. AIDP is the most common type. Miller-Fisher is relatively rare. Amman-Amsan are relatively rare. This is rare. Okay, AIDP being a demyelinating disorder, why only myelin gets targeted? Because antibody produced here have their target antigen on the myelin. That's why myelin is getting targeted. So what is the antibody that is seen here? Anti-ganglioside M1 antibody or anti-GM1 antibody. And in Amman and Amsan, generally we get anti-GD1 antibody, GD1A antibody. And in Miller-Fisher syndrome, we carry anti-GQ1B antibody. So antibodies help us to differentiate apart from nerve conduction study. And what we know so far is if there is demyelination, prognosis is good because remyelination can happen efficiently. So this carries good prognosis. But if there is axonal injury, right, these both carry poor prognosis because there is axonal injury. Now Miller-Fisher actually is mixed axonal as well as demyelination, but this Miller-Fisher has some peculiarities. What is it? This Miller-Fisher primarily affects sensory neurons more than the motor neurons. So this affects sensory more than motor neurons. So can this cause death? The death is most commonly because of respiratory muscle paralysis. And if motor neurons are not affected much, I will not have chance of developing the respiratory paralysis. So then my chance of death is less. So this also carries good prognosis because it is predominantly affecting the sensory neurons. And because it affects the sensory neurons, it produces a very important symptom. What is that? Yes, the proprioception is required for me to maintain my upright posture. If proprioception is taken away, I will have ataxia. So this Miller-Fisher variant has ataxia. So Miller-Fisher syndrome is characterized by this, leads to ataxia, and along with ataxia we will also have ophthalmoplegia, weakness of the extraocular muscles, but minimal or no motor weakness. That's very peculiar of it, right? And because of that it carries good prognosis. So this also carries good prognosis because there is minimal to no motor weakness, because motor neurons are not affected much. There is minimal to no motor weakness. Okay, clear? These are the subtypes. Subtypes basically help me to understand the prognosis. These carry poor, these carry good. Now after the subtype classification, we will come to the management of GB syndrome. How will I manage a case of GB syndrome? There are 2-3 things here. Here antibodies are causing demyelination, and if more and more neurons get demyelinated, one day respiratory muscles will get affected, patient will land up on ventilator. After that, God only knows his fate, because complications of ventilator are known to occur. So best bet is, let me not allow the progression of the disease. How can I not allow the progression of the disease? If I take the antibodies out from the body, no more demyelination, no more axonal injury, and hopefully the disease will not progress. So how can I take the antibodies out from the body? Yes, plasma exchange or IVIG. Studies have shown IVIG is slightly superior to plasma exchange. But before that, I have to also think about it. What if the the disease progresses to involve the respiratory muscles? I have to put him on ventilator. But you all know that ventilator is better put electively than as an emergency procedure once the saturation has dropped. So what is the parameter that I should monitor to know when the respiratory muscle involvement is prompting towards intubation? Right, we will be monitoring FVC. So for all patients with myasthenia, GB syndrome, we have to monitor FVC. So regularly we have to monitor FVC, and if FVC becomes less than 15 ml per kg, it is better to intubate the patient and put on ventilator. Intubate and put the patient on mechanical ventilation. So this can be a potential MCQ. What is the parameter to monitor for the respiratory weakness? It is FVC. And when is the intubation recommended? FVC less than 15 ml per kg. Okay. Now that is about respiratory. Now how I prevent this from happening? By removing the antibodies. So for that, we can follow IVIG or the plasma exchange. IVIG is considered superior. Studies have shown slight superiority of IVIG, right? That's about our GB syndrome. The next topic I'm going to address is one more important topic, which is called as amyotrophic lateral sclerosis, or ALS. So this ALS is a motor neuron disease. It is a mixed motor neuron disease. So when I say mixed motor neuron disease, this is a neurodegenerative disease where UMN plus LMN are getting degenerated. UMN plus or LMN getting degenerated. Why they degenerate? It is a neurodegenerative disorder. It's a neurodegenerative disorder, and most of the neurodegenerative disorder are due to accumulation of some or the other things in the neurons. So what is being accumulated here? It is due to accumulation of what we call as, like Alzheimer's is due to amyloid beta and tau. Parkinson is due to accumulation of alpha-synuclein. These are due to accumulation of tar-derived protein 43 and ubiquitin immunoreactive proteins or inclusions. Ubiquitin immunoreactive inclusions. Ubiquitin immunoreactive inclusions. As of now, we don't know the exact causes why they accumulate, but we are aware of some risk factors. So what are the risk factors for someone to develop ALS? The risk factors for someone to develop ALS are: number one, age more than 55 years. Age more than 55 years. Apart from that, the other risk factor is having a mutation in a gene called as ORF. Important MCQ. Apart from that, another mutation that I want you to remember is superoxide dismutase 1 gene. This is a potential MCQ point. Superoxide 1 mutation increase the risk of developing ALS. So these patients, what clinical features they come? Because their motor neurons are dying one after the other, they present with two things. One, bulbar or pseudo-bulbar palsy. What do you mean by bulbar palsy? Cranial nerves get affected. Cranial nerves also have motor neurons, lower and upper. Lower motor neurons are there in the brainstem. From there, it is coming to the muscle. So if that get affected, it's called bulbar palsy. Upper motor neurons are there in the corticobulbar tract. If that gets affected, we call it as pseudo-bulbar palsy. And what are the symptoms of this bulbar or pseudo-bulbar palsy? The symptoms are 3 Ds. What are those 3 Ds? One is dysphagia, difficulty to eat, dysphonia, and the third one is dysarthria, difficulty to articulate speech, difficulty to produce voice, difficulty to articulate. Production difficulty is dysphonia, difficulty to articulate is dysarthria, bulbar and pseudobulbar palsy. Okay. Plus, these people will have progressive limb weakness. Progressive limb weakness, which makes them wheelchair bound pretty soon. Okay, clear? And these are going to be our clinical features. You have seen Stephen Hawking, who was a classical case of ALS. So you have seen him on wheelchair because he had progressive limb weakness, because motor neurons upper and lower both are being destroyed. And you have seen him speak with the help of a machine because he had dysphonia, dysarthria. It's a classical example. Now, when I get this patient, how am I going to diagnose these patients? For the diagnosis, we follow what is called as L-Escorial criteria. What is it called? It is called as L-Escorial criteria. L-Escorial criteria. So what L-Escorial criteria says? Our human body, we have divided into different regions. So what are those regions? Head and neck is one region. Then my upper limbs are one region, and then my lower limbs are another region. Okay. Head and neck is called as bulbar region. This is called as bulbar region. Why is it called as bulbar region? Because the nerve supply to it comes from cranial nerves, who originate in the bulb or the brainstem. And then upper limb, I will call it as cervical region. Upper limbs are called as cervical region because the nerve supply to this comes from brachial plexus, which is originating in the cervical segments of the spinal cord. So this is going to be my cervical region. And then the thorax. Thorax, I will label it as thoracic region because the nerve supply to it come from the thoracic segments of the spinal cord, including the abdomen, right? Up to umbilicus and all is coming from T10, T11, T12. So this region we will call it as thoracic region. And then the lower limbs will be called as lumbosacral region. I'm going to call them as lumbosacral region. Why? Because the nerve supply to this region comes from lumbar plexus and sacral nerves. Lumbar plexus and sacral nerves. So this will be called as lumbosacral region. So among these regions, on examination, if I get involvement of LMN and UMN in at least 3 regions, then we will call it as ALS according to LS Coriel criteria. So if I have findings of UMN plus LMN involvement in more than or equal to 3 regions, that is equivalent to definitive ALS. Less regions, it can be still ALS, but we will call it as possible, probable ALS and all. But if 3 or more than 3 regions shows LMN and UMN involvement, for example, like right upper limb shows LMN and UMN involvement, 1 region done. Left upper limb also shows 2 regions done. Then left lower limb also shows 3 regions done. Done. It is a case of ALS according to LS Coriel criteria. Once I have diagnosed, how am I going to manage these patients of ALS? The management of ALS will primarily focus on supportive care because they have wheelchair bound. They need, like they are having progressive limb weakness, they might need wheelchair and other supportive care for mobility. They have difficulty to speak, so they might require external assistance like Stephen Hawking. They have difficulty to eat, so they might require a gastrostomy. So supportive care is important, so we will definitely do that. But apart from that, traditionally we were using 2 drugs. One was riluzole and another one was edaravone. Both are neuroprotective agents. They protect the death of motor neurons to some extent, not greatly effective. To some extent they are useful, but both these drugs used to increase lifespan by approximately 3 months. So they are not very highly effective. That's why we were always on the search for new drugs. And last 2 years, we have a new drug in the market. And this is the MCQ that I'm strongly anticipating. What is the drug I'm talking about? This drug is called as tofersen. This is not for all cases of ALS. It is for those ALS patients who have superoxide dismutase 1 mutation because it is an antisense oligonucleotide for superoxide dismutase 1 mutation. So if I have SOD1 mutation, this drug is useful. If I have ORF mutation or no mutation identifiable and I still have ALS, this drug is not useful. So 2 MCQs can be asked. They will ask what is the newly approved drug. It is tofersen. It is a newly approved drug. They will also ask what is its mechanism of action. It is an antisense oligonucleotide. ASO stands for antisense oligonucleotide. Newly approved drug, antisense oligonucleotide. And then the third question they will ask you is it for all or it is for selective? It is for selective patients who have the mutation in superoxide dismutase 1 gene. It's not for everyone, right? So we have addressed 3 major diseases from the neurology. Other important topics we're expecting is the multiple sclerosis. If you want to see in detail, there is a YouTube lesson available on the Reed Harrison series. You can go through. Majority of the questions are in the MS are going to come from the McDonald's criteria. Take some time and quickly revise that as well. Okay. Now let us get into other important topics from rheumatology. In rheumatology, what are the important topics? If you ask me 3 important topics, I would say rheumatoid arthritis, SLE, and scleroderma, right? So first we will start with SLE. In terms of exam questions, right, what important things you have to remember is for all rheumatological disorders, these are autoimmune disorders, right? So there will be some antibodies. So you need to know antibodies and their correlations. They correlate with which organ involvement or which symptom involvement. Second thing you need to know is if there is a diagnostic criteria, what are the criteria involved, whether it is worth remembering or not. Third thing, all these rheumatological disorders will have one principal cytokine, the main cytokine causing the inflammation. That you should know because we will be using drugs to block that. Clear? So let us start with SLE, systemic lupus erythematosus. Okay. Now we are already familiar that it is an autoimmune disorder which is more common in females than males with a ratio of 9:1, a number that everyone knows, right? It is a multi-organ inflammatory disease, right? So they will ask you, what are the organ manifestations? So when we talk about organ manifestations, right, let me start with the brain directly, top to bottom, let's go. So when it comes to brain, skin is the most commonly affected organ. Second most common is the musculoskeletal system. But if they're asking you what is the manifestation, most common manifestation, most common CNS manifestation, it is going to be cognitive dysfunction. A lot of patients with SLE end up developing mild dementia. They have cognitive dysfunction. That is the most common CNS manifestation. If they ask you what is the most common dermatological manifestation, the most common dermatological manifestation is going to be malar rash or butterfly rash. Apart from this malar rash, you can also have the subacute cutaneous lupus erythematosus and discoid lupus erythematosus, which is chronic rash. Malar rash is on and off. This is a photosensitive rash. Only when there is sun exposure it comes. It may disappear if there is no sun exposure. And this rash has characteristic nasolabial fold sparing. If they ask you what is the most common respiratory system manifestation, what should be your answer? Yes, it causes serositis. So there will be pleuritis. Pleuritis is the most common respiratory system manifestation. You can have pleuritis with or without pleural effusion. Apart from that respiratory system manifestation, you can also have what is called as shrinking lung syndrome. Shrinking lung syndrome. This is a potential MCQ point. So what is a shrinking lung syndrome? This is a restrictive type of respiratory disorder. It is a restrictive respiratory disorder. But normally what restricts? Either the fibrosis of the lung, in that case we will call it as ILD, right? Or the pleural diseases. So here it's not lung fibrosis. It's not pleural disease. It is the overall chest thorax, right? The overall thorax is getting fibrosed and shrunken. So it is causing the restriction. So you will have restrictive pattern on the PFT, but the lung parenchyma will appear normal on the HRCT. So restrictive respiratory disease, what is a typical restrictive pattern? FEV1 by FVC ratio will be more than 0.7. FEV1, FVC may be reduced, but the ratio will be more than 0.7. That is restrictive pattern. Along with that, you will have normal lung parenchyma on the imaging, but still the lung volume is reduced. Parenchyma is normal, it's not fibrous, there is no ILD, but lung volume is reduced because of the supportive structure or the integument being fibrous or constricted, right? In the question they will also mention, because lung volume is reduced, you will have elevated hemidiaphragm. Elevated hemidiaphragm. Okay, that is what we call as shrinking lung syndrome. The examiner may also ask you what is the most common CVS manifestation. The most common CVS manifestation is going to be pericarditis. Pericarditis. What other manifestation we can expect? We can also develop endocarditis, myocarditis. It causes pancarditis, affect all the layers. Endocardium is not because of infection, it's just the inflammatory cytokines causing. So we will call it as Liebman-Sachs endocarditis. It's a form of sterile endocarditis. Liebman-Sachs endocarditis. It's a form of sterile or aseptic endocarditis, right? They will also ask you what is the most common. Okay, let us see what all we have missed. Most common musculoskeletal manifestation. Most common musculoskeletal manifestation. Most common musculoskeletal manifestation is arthralgia followed by arthritis. Arthralgia and arthritis. And when we are talking about arthritis, you know, there are different types: polyarthritis, monoarthritis. So this actually causes polyarthritis, just like rheumatoid arthritis, which causes polyarthritis. And when it is causing polyarthritis, another thing I want you to know is whether it affects upper limb more or lower limb more, small joints more or large joints more, and whether it is bilaterally symmetrical or asymmetrical. So here it is just like rheumatoid arthritis. It is also affecting bilaterally symmetrical polyarthritis. It is affecting upper limb joints more than lower limb joints. This affects small joints of the upper limb more than large joint, just like rheumatoid arthritis. Then what is the difference between rheumatoid arthritis and this? It is also small joints of the hands and feet, upper limb more than lower limb, symmetrical, RA also symmetrical. What is the difference? In rheumatoid arthritis, there is joint deformities. There is no joint deformities in SLE. This is a non-deforming polyarthritis. This is non-deforming. Sometimes you may have something called as Jacquard's arthropathy, where the soft tissues of the joint become weak. So you may have some apparent deformities, but they are reducible. There's no irreversible deformities. The true irreversible deformities happen in case of rheumatoid arthritis. These are non-deforming polyarthritis that we are getting. Clear? What is the most common hematological manifestation? Most common hematological manifestation is anemia of chronic diseases. Most common hematological manifestation is anemia of chronic diseases. Anemia of chronic diseases, which is a normocytic normochromic anemia, as we all know. It is going to be normocytic normochromic. Now the next thing is we need to know the antibodies that we are expecting in a patient of SLE, right? So what are the antibodies and what are their clinical correlation? That is the next level of MCQs that they will ask. So the antibodies that we are expecting in a patient with SLE. The first and the most common antibody, which is also asked as an MCQ, what is the most sensitive antibody in SLE? The most common and most sensitive. Anything that is most common will be the most sensitive. That is going to be ANA. Then they may ask you what is the method used for this ANA estimation and what is the titer to consider it as positive. So the method followed for this is indirect immunofluorescence. Indirect immunofluorescence, IIF, indirect immunofluorescence. And the titer to consider it as positive more than 1:80. More than or equal to 1:80. 1:40 is very common, seen in up to 5% of population. Then they will ask you what is most specific antibody. Most sensitive is ANA, but what is most specific antibody? Most specific antibody is anti-Smith antibody. It is anti-Smith antibody. Then they will ask you what is the second most sensitive. And they will also ask you what is the second most specific. Both are same. The second most sensitive and second most specific, both are same. And second most specific, both are same. And that is anti-dsDNA, second most specific. Anti-double-stranded DNA antibodies. Anti-dsDNA antibodies are the most specific or second most specific, second most sensitive. And they have some added role. ANA elevated, used once for diagnosis, not repeatedly done to know whether the treatment response is there or not. But anti-dsDNA correlates with the disease severity. Higher the titer, higher is the disease severity. If I start treating and disease comes down, anti-dsDNA titers come down. So that's why it has a role in monitoring the response to treatment. So anti-dsDNA, first thing you need to know is it correlates with disease severity. Disease severity. And it also correlates with increased risk. As the anti-dsDNA titer goes on high, you know that there is increased risk of developing kidney involvement, which is called as lupus nephritis. Lupus nephritis. Okay, clear? Then they will also ask you which antibody correlates with the drug-induced SLE. So drug-induced SLE, the antibody that correlates with the drug-induced SLE is anti-histone antibodies. It is antihistone antibodies, right? So similarly, there is another antibody that is important for us to know, which is called as anti-SSA, or also called as anti-Rho antibodies. These anti-Rho antibodies or anti-SSA antibodies correlate with many things. One of them is subacute cutaneous lupus erythematosus, one of the types of skin rash. Second, it also correlates with the risk of developing Sicca syndrome, or a secondary Sjogren's syndrome, as we call it. Third, very, very important, repeatedly asked MCQ, which antibody correlates with neonatal lupus? So if there is a patient mother, or like a pregnant woman with SLE, and she carries this anti-SSA or anti-Rho antibodies, she has a high risk of transferring these antibodies to the newborn, and the newborn may develop what we call as neonatal lupus. This is a potential important MCQ point. So don't forget this. Which antibody correlates with neonatal lupus? It is the anti-SSA or anti-Rho antibodies. Right. We also have another similar antibody called as anti-SSB or anti-La antibodies. These only correlate with Sicca syndrome. They correlate with risk of developing secondary Sjogren's syndrome or Sicca syndrome. They do not correlate with the neonatal lupus or subacute cutaneous lupus erythematosus. So that's why this is particularly important. Okay, clear? So these are some major antibodies that you need to remember. Okay. Now we have a classification criteria for SLE, which is called as the the American College of Rheumatology EULAR criteria. So there they might ask you what is the essential or entry criteria. So whole criteria you don't have to remember. You have to remember that in that criteria there is an essential or entry criteria. Followed by that there is a lab and clinical criteria. Both put together we need 10 or more than 10 points to classify the case as SLE. So the criteria we are going to call it as the classification criteria. It's not a diagnostic criteria per se. You can diagnose without the criteria being met. The classification criteria is currently what we follow is American College of Rheumatology EULAR criteria. Earlier it was SLICC criteria. So according to this, we have an entry criteria. What is the entry criteria? Without this criteria being met, we don't consider further evaluation for classification. What is its criteria? ANA titer, ANA positive with a titer more than or equal to 1:80 according to the standard method, which is indirect immunofluorescence. That is the entry criteria. After that, we will have lab and clinical criteria. So we need more than or equal to 10 points, out of which, so I need entry criteria plus more than or equal to 10 points, out of which at least 1 point or 1 score, 1 point is from clinical criteria. Among this, and the 2 years or 3 years ago, they had asked one question on this ACR EULAR currently running criteria. Which of the following is the newly introduced domain? So there are clinical and lab criteria. In the clinical criteria, there were neurological manifestations, dermatological manifestations. So there were segments, and a new segment was added. So that was asked. So I want you to remember that newly introduced domain in the clinical criteria, and that domain is constitutional symptoms. Earlier only organ systems were involved. No constitutional symptoms were given weightage. Constitutional symptoms. And what is the constitutional symptom that is being considered here for giving points? It is fever. So a patient of SLE or patient where we are suspecting SLE, if they have fever, we give 2 points. So fever also is now part of this criteria. Okay. Once we have diagnosed, we have to talk about its management. And when it comes to management, what are the important things that I have to keep in mind, right? I forgot to mention this point. The principal cytokine involved in the pathogenesis of SLE, the main cytokine. It is interferon 1. Interferon 1. In case of rheumatoid arthritis, it is going to be transforming growth factor beta. Sorry, tumor necrosis factor alpha, TNF alpha. In case of scleroderma, it is transforming growth factor beta. So scleroderma patients, we don't have good treatment because we don't have TGF beta blockers as of now effective. But in case of rheumatoid arthritis, we have TNF alpha blockers, right? Can I block interferon 1? Yes, there are new drugs available. But if they ask you what is the drug of choice for treatment of SLE, which is the initial treatment of choice. The drug of choice for treatment of SLE is hydroxychloroquine or HCQS. Hydroxychloroquine or HCQS is the drug of choice for the treatment of SLE. If that is not sufficient, we have to think of other drugs like immunosuppressants and steroids. There are a few new drugs that I want you to remember, the newer drugs that are used for treatment of SLE. The first one I want you to remember is belimumab. And the second one I want you to remember is the new drug called as anifrolumab. Belimumab is a B lymphocyte stimulant, B-LYS inhibitor. So it inhibits the B lymphocytes. All these antibodies are produced by B lymphocytes. So if I inhibit them, antibody production comes down, the disease activity comes down. Anifrolumab holds it in the name. What is the principal cytokine? Interferon 1. So can I block it? Yes. Anifrolumab is a drug that blocks interferon 1. The name says anti-interferon monoclonal antibody. Right. So it is there in the anifrolumab. It's an interferon 1 antagonist. So it is a monoclonal antibody against interferon 1. This is an anti-interferon 1 monoclonal antibody. This is a potential MCQ. This is already asked in the previous NEET SS. There is a high chance that INI-SS, so there is a high chance that it may filter into the INI-CET as well. Which of the following is recently approved monoclonal antibody for the treatment of advanced cases of SLE? It is going to be anifrolumab. Okay, so that completes our SLE. Now, the next topic I'm going to take, I'll not touch the rheumatoid arthritis because it will be covered in orthopedics. So the next topic we're going to take is scleroderma. Scleroderma. What is scleroderma? It is a disease where autoimmune damage happens to the blood vessels and there is overactivation of fibroblasts resulting in fibrosis of skin and other organs, right? The thickening of the skin is what we call as scleroderma. This scleroderma is also an autoimmune disorder, so typically more common in females than males. And this scleroderma has two subtypes. What are these subtypes? We will call these subtypes as limited cutaneous and diffuse cutaneous. What is the basis for this? The basis for this classification is the extent of skin involvement. So if there is thickening of the skin which is restricted to distal to elbow joint, then it is called as limited cutaneous. If it extends proximal to elbow joint in the upper limb or proximal to knee joints in the lower limb, it will be called as diffuse cutaneous. So we have two major types. One is limited cutaneous, the other one is diffuse cutaneous. In limited cutaneous, the skin fibrosis is restricted to the areas distal to the elbow joint. It does not cross the elbow joint. Skin thickening restricted to elbow and knee joint. In the lower limb, it does not cross knee joint. In the upper limb, it does not cross elbow joint. Then we will call it as limited cutaneous. There can be facial involvement, but the limb involvement doesn't cross elbow and knee joint. But if it crosses elbow and knee joint, then we can call it as diffuse cutaneous. Then we will call it as diffuse cutaneous. So in diffuse cutaneous, the skin involvement extends proximal to the elbow and knee joint. Then we will call it as diffuse cutaneous. Is it just based on this extent of skin involvement, basis is same, but the two diseases behave totally differently, right? Why? The patients of limited cutaneous, these are particularly prone for severe Raynaud's phenomenon, digital tip or fingertip ulcers, pulmonary hypertension, and mortality due to pulmonary hypertension. Apart from that, they can have calcinosis cutis. That's why this is also called as CREST syndrome. CREST syndrome. So these patients will have calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, right, and telangiectasia. That's why it is called as CREST syndrome. Diffuse cutaneous is particularly more prone to develop the scleroderma, renal crisis, and ILD, basically organ failures. So these limited cutaneous patients have increased risk of developing Raynaud's phenomenon. Both of them develop, but these develop Raynaud's phenomenon with fingertip ulcers. Fingertip ulcers. They will also have calcinosis cutis, the calcification of the skin, especially fingertips, calcinosis cutis. Then they will have esophageal dysmotility. They will have telangiectasia, vascular abnormalities called telangiectasia. Apart from that, both of these patients can have microstomia, difficulty to open the mouth. We will call it as microstomia. On the other hand, these patients of diffuse cutaneous, they will also have Raynaud's phenomenon, but low risk of fingertip ulcers. Low risk of fingertip ulcers. Low risk of calcinosis cutis, but they are prone to develop a high renin hypertension. This high renin hypertension is also called as scleroderma renal crisis. It's called as scleroderma renal crisis. Plus, these are also prone to develop interstitial lung fibrosis or pulmonary fibrosis. I forgot to mention these patients of limited cutaneous are prone to develop what we call as pulmonary arterial hypertension. Okay. Now, how do I remember? I may get confused between these and that, right? So, most important thing you have to remember is whenever diffuse cutaneous comes to your mind, think about fibrosis. And whenever limited cutaneous comes to your mind, think about vasculitis. Don't write it in a theory paper. I'm just giving you hint to remember. Fibrosis or organ involvement. So in diffuse cutaneous, there is more tendency to cause organ fibrosis, like you are getting ILD, renal dysfunction. But in limited cutaneous, it's more about vessel damage. So that's why you're getting pulmonary arterial hypertension, pulmonary artery hypertension. You're developing telangiectasia. You're developing Raynaud's phenomenon with digital tip ulcers or gangrene. Right? So think about blood vessel when you think of limited cutaneous. Think about diffuse cutaneous when you think about organ fibrosis. So that way you will be able to answer the differences. Okay, now before I take you forward on this, should I wait for the full extent of skin involvement to manifest before I label it as diffuse cutaneous or limited? No, antibody profiling helps. So this patients with diffuse cutaneous have an antibody. What is the antibody of the diffuse cutaneous? It is anti-DNA topoisomerase enzyme. DNA topoisomerase antibody, which is also called as anti-Scleroderma 70 antibody, anti-SCL70 antibody. And the antibody that I'm getting in the limited cutaneous is usually anti-centromere antibody. Anti-centromere antibody. Okay. So the way to remember this is you can remember it as D4D, DNA topoisomerase for diffuse cutaneous, right? And then anti-centromere for limited cutaneous. So any patient, indirectly they will twist and ask the question. There is a patient with scleroderma with anti-SCL70 antibody positive. this patient is prone to develop or is at increased risk of. He's not at increased risk of digital gangrene or finger gangrene. He's not at increased risk of developing pulmonary arterial hypertension, but he's at increased risk of developing scleroderma, renal crisis, and ILD. On the other hand, there is a scleroderma patient with this anti-centromere antibody positive. He is prone to develop fingertip ulcers. He is prone to develop calcinosis cutis, esophageal dysmotility, telangiectasia, microstomia, pulmonary arterial hypertension. Microstomia happens in both cases, but other are specific, right? Clear? Some image-based questions are also possible, so I have put them up. So this is where you can see the skin thickening, right? There is skin thickening here, and this skin thickening is also called as sclerodactyly. It's called as sclerodactyly, or it is also called as sausage-shaped fingers. Sausage-shaped fingers. Right, you can see that also in these patients. On the other hand, what do you notice here? This I forgot to mention. Some of these patients, both limited and diffuse cutaneous, may end up developing this punctate depigmentation. This is called as salt and pepper skin. Salt and pepper skin. Okay. Now I'm going to diagnose these cases. How will I diagnose? Diagnosis clinical. Scleroderma also has a classification criteria. At this point of time, it's not required for you. So only thing I want you to remember for diagnosis, even if I'm following the classification criteria, right? If I'm following classification criteria, which is from ACR or ULAR, I need more than or equal to 9 points to classify it as scleroderma. And remember here, if there is skin thickening extending proximal to the metacarpophalangeal joint, bilateral, that is sufficient to give you 9 points. So if there is skin thickening extending proximal to metacarpophalangeal joints bilaterally, means both the, like if I look at the hands of this individual, so you will have this metacarpophalangeal joints, right? So this is what we call as metacarpophalangeal joint, MCP joint. So if the skin thickening extends proximal to this metacarpophalangeal joint, bilaterally, that is more than enough to call it as scleroderma without any investigations. But I want you to draw attention to another important investigation that may be asked as a potential MCQ, and that is nothing but nail fold capillaroscopy. Because Raynaud's phenomenon can also happen physiologically on exposure to cold. That is called as Raynaud's disease. So this helps us to differentiate between an abnormal Raynaud's phenomenon due to scleroderma and the physiological Raynaud's phenomenon due to Raynaud's disease. So what it shows in nail fold capillaroscopy, when we look at the nail fold capillaries, they will be abnormal in case of scleroderma, but they will be normal in case of Raynaud's disease. Raynaud's disease is nothing but an exaggerated physiological response to cold. Many women do experience it. So what are the abnormal nail fold capillaroscopy findings? When we look at the nail fold capillaries, they are neatly organized like this. Neatly organized like this. So you will see that the nail fold capillaries are pretty neatly organized. But in case of scleroderma, there is vasculitis, there is damage to the capillaries. So you will have some capillaries hyperproliferating, we will call them as giant capillaries, and distorted architecture, and some places there may be no capillaries. So this is how it may be looking. So first thing you are noticing here is there are giant capillary folds. Giant capillary folds. Second, there may be avascular zones where the capillaries are gone, they are dead, avascular zones. This is called as abnormal. This can be seen in scleroderma. Okay. So once I have classified or diagnosed, the next question is how am I going to manage these patients? The management of scleroderma, as of now, there is no specific treatment available. It is going to be symptomatic. Raynaud's phenomenon, you can treat them with calcium channel blockers, which are vasodilators. If there is esophageal dysmotility, you can give prokinetics. That's how we treat. Why? Because I forgot to tell you the principal cytokine in these patients. The principal cytokine involved in these patients is going to be, what is the principal cytokine? It is the transforming growth factor beta, TGF beta. We don't have effective drugs right now lined up for these patients. In future, we may have. Clear? So that completes the important topics from rheumatology. Next, let me address few important topics from nephrology before we move to the pulmo. Majority of the questions in nephrology from glomerular disorders are going to come from pathology. Majority of the questions from CKD are going to come from complications, right? AKI definition or classification may be important. Okay, so what I will cover now is how do I diagnose, because nowadays questions are integrated. So it starts in medicine, the symptom story. From there, the question takes you to pathology. What will be the biopsy findings, right? Where there will be deposition of immune complexes, whether it is in the glomerular basement membrane or in what space. Those are the questions asked, but you should be able to recognize the question first, right? So what we will do is we will just take a quick look at the nephron. So we know that the structural and functional unit of the kidney is going to be a nephron, which has a glomeruli and tubules, right? It has a Bowman's capsule and tubules. Tubules will have proximal convoluted tubule. Then we will have this loop of Henle descending and thick ascending limb of loop of Henle. Then we will have distal convoluted tubule, which will drain into what we call as collecting ducts, right? And we also know that blood comes into this nephron, through okay, so blood comes into these nephrons through an afferent arteriole and leaves through an efferent arteriole, and we will have these capillaries, what we call as glomerulus. So this is going to be an afferent arteriole. Let us say this is an efferent arteriole. Now, when a disease affects the kidney, right, it may be affecting the glomerulus. Then we will call it as glomerulonephritis, right, or glomerular disorders. The disease may also affect the tubules. In the tubules, you have studied about specific syndromes like Bartter, Gitelman's, Liddle's, and all. Apart from that, you have acute tubular necrosis and chronic tubulointerstitial diseases, right? And then surrounding this is your interstitium. That can get affected. Then we will have what is called as interstitial nephritis. So first, let us understand how do I recognize the glomerular disorders. So first thing we are going to address is what we call as glomerular disorders. And when we are talking about glomerular disorders, when glomeruli get affected, they present with one of the two symptoms. One of them is nephritic syndrome, the other one is nephrotic syndrome. So patients of glomerular disorders present with either nephrotic syndrome or nephritic syndrome. Nephrotic syndrome or nephritic syndrome. Now, what are the cardinal manifestations of this nephritic syndrome? Patients with nephritic syndrome will have, first, they will have hypertension. Patients with nephrotic can also have hypertension. But along with hypertension, the nephritic syndrome patients will have proteinuria. And this proteinuria is usually subnephrotic range, means minimal proteinuria, not as gross as what we get in nephrotic syndrome. So it will be less than 3.5 grams per day. But here we will have proteinuria, which is the nephrotic range, means high amount of proteinuria. So proteinuria is going to be more than 3.5 grams per day. Then third, in nephritic syndrome, we often have hematuria, which is not usually encountered in nephrotic syndrome, right? In nephrotic syndrome, instead of hematuria, what I get, I will have other systemic manifestations. We will have dyslipidemia, right? We can have increased LDL-C and triglycerides. We can have dyslipidemia. And because I'm losing so much of protein in urine, right, I will have hypoalbuminemia. And whenever I lose so much of albumin, albumin is an determinant of the oncotic pressure. So when I lose that, I will start losing the fluid into the third space. I will develop with what we call as generalized edema or anasarca or generalized edema. Here we will have mainly periorbital edema in nephritic syndrome. Okay, I have to also address one more point, because there are other causes for hematuria. If I have a renal stone, ureteric stone, urethral stone, bladder stone, cystitis, in all cases I can have hematuria. Then how do I differentiate that this particular question where patient has hematuria is actually talking about the nephritic syndrome? The clue for that is these hematuриas is accompanied by dysmorphic RBCs, because when there is glomeruli damaged and RBCs squeeze through it, they become out of shape. So we'll have dysmorphic RBCs. So dysmorphic RBCs is a potential clue. And not just the dysmorphic RBCs. These dysmorphic RBCs will go and get impregnated on what we call as, see, normally in these renal tubules, there is formation of casts called as hyaline cast, which is made of Tom Horsfall protein. But then RBCs coming from here will get impregnated on it, and then we will convert these hyaline casts into what we call as RBC casts. So we can have dysmorphic RBCs, which is highly suggestive of nephritic syndrome or glomerular injury, plus we can have RBC casts. So if I know which glomerular disorders present with nephritic syndrome and which glomerular disorders present with nephrotic syndrome, my job is already sorted or done. So which disorders present with the nephritic syndrome? The disorders, glomerular disorders that will present with the nephritic syndrome, right? That includes post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. Another example that comes to my mind is right now IgA nephropathy. IgA nephropathy. In your pathology, you may get more list. You can definitely go through that. Now, which disorders present with this nephrotic syndrome? The first thing that should come to your mind is minimal change disease, which is the most common cause for nephrotic syndrome in children, right? Apart from that, you can also have this focal segmental glomerulosclerosis presenting as nephrotic syndrome sometimes. Okay. Apart from that, membranous nephropathy. Membranous nephropathy is another glomerular disorder which may present with nephrotic range proteinuria, right? So I'll give you some few extra points to recognize these diseases. PSGN typically happens after group A streptococcal pharyngitis, right? So here usually group A streptococcal pharyngitis, because there is an infection trigger disorder, so you will have gas pharyngitis followed by that. Usually it takes more than 1 week, usually 2 to 3 weeks, but at least 1 week it takes, more than 1 week for the patient to develop post-streptococcal glomerulonephritis. Then he will present with this hypertension, proteinuria, hematuria, periorbital edema. So any question which says I have sore throat and then 1 week later I presented with these symptoms is talking about PSGN. Okay. IgA nephropathy is also, in PSGN, it is due to immune complex deposition of complexes, antibodies. Along with that, there is a formation of complex with the antigen, bacterial antigen, and it goes and gets deposited in the glomeruli. That's why glomeruli are getting damaged. In IgA nephropathy, it is due to deposition of IgA1 subclass of immunoglobulins without complexing with the antigen. There's no antigen. Just IgA1 goes and gets deposited. So there is deposition. In IgA nephropathy, there is deposition of IgA1 subclass. And here also usually pharyngitis is a trigger, because once there is infection, body produces IgA, and this IgA will go and get deposited in the glomeruli, right? So here also it is pharyngitis, need not be group A streptococcal, but pharyngitis. But here from pharyngitis to IgA nephropathy usually progresses in less than 1 week, usually less than 3 days. So it is also called, IgA nephropathy is also called as synpharyngitic nephritis. It is called as synpharyngitic because almost simultaneously the nephritis is occurring, synpharyngitic nephritis. But PSGN is post-streptococcal glomerulonephritis. Okay, clear? So similarly, minimal change disease, I'm not going to talk much about it. You know that you will be encountering it in pediatrics. This is the most common cause for nephrotic syndrome in children. Right? FSG is typically more common in HIV patients, right? That is why it is also called as HIV associated nephropathy or HIVAN. Okay. Now membranous nephropathy, it presents with nephrotic syndrome. This is typically more common. This could be what we call as primary membranous nephropathy and secondary membranous nephropathy. Secondary membranous nephropathy is typically more common in hepatitis B patients and to some extent hepatitis C patients or other disorders. Primary membranous nephropathy, there is no secondary trigger here. Then what is the reason? These patients have an antibody called as anti-phospholipase A2 PLA2 receptor antibodies. It is due to anti-phospholipase A2 receptor antibody. Potential MCQ points, so I want you to remember these as well. So is it difficult for us to recognize which glomerular disorder a particular question is talking about? No. If you can differentiate nephrotic and nephritic, and if you know the table of glomerular disorders which produces nephrotic and which produces nephritic, you will be able to reach the diagnosis. Beyond that, they may be asking you about extra pathological findings. I'm not going to discuss because of the lack of time, but I will leave a table. Either you can go through Dr. Ranjit's notes to understand different pathological findings in different glomerular disorders, or you can refer to this table. Like for example, I'm just giving you an example right now. Minimal change disease, which is the most common cause for nephrotic syndrome in children. There will be no macroscopic, gross microscopic or macroscopic change in the kidney. Only under electron microscopy, we will be able to see effacement of foot processes, right? So these kind of questions can be asked. Membranous nephropathy, I was talking about it. It is associated with hepatitis B. Apart from that, anti-phospholipase A2 receptor antibody. And in the biopsy, you will see subepithelial deposition in the form of complex deposition in the form of spike and dome appearance. This is a potential MCQ point, right? So go through this table to get those pathology key points or go through the Ranjit's notes. Now, only additional thing I want you to address in nephrology, apart from this table, is in the nephro, they will also ask you about tubular disorders. Okay, so in the tubular disorders, renal tubular acidosis and the Bartter, Gitelman, and all those are important. I have addressed them in a Telegram discussion. So today, one more important thing that I want you to know to get into the examination hall is the kidney can also be damaged in an acute form, which is called as pre-renal AKI and renal AKI. AKI basically. There they may ask you to differentiate between pre-renal AKI and AKI. Acute tubular necrosis. That comes under a tubular disorder. So tubular disorders will have renal tubular acidosis, plus it will have your acute tubular necrosis and your Bartter, Gitelman, and Little syndrome, right? So right now, let us address how to differentiate between pre-renal AKI and pre-renal AKI versus acute tubular necrosis. Acute tubular necrosis is where there is a necrosis of tubules acutely. Pre-renal AKI is because of the reduced perfusion of the kidneys. So what is the best investigation to differentiate between the two, right? Let me give you a very quick thumbs up. In pre-renal AKI, there is decreased perfusion of the kidney. Because of that, low blood coming into it, it's not able to filter. Right? So when that happens, when you have lost the circulating blood volume, dehydration, hypotension, shock. In that case, what is your expectation from the kidney? Should I absorb more water or I excrete more water in the urine? I should absorb more, right? Because I have hypovolemia. That's the most common cause for prerenal AKI. So I should absorb more sodium and water. So the urine that is going out will be highly concentrated, right? So what will be the urine specific gravity? So in case of pre-renal AKI, urine specific gravity will be high. But in case of acute tubular necrosis, so I will have increased urine specific gravity. So urine specific gravity will be high. Urine specific gravity will be high. You can also say urine osmolality will be high because it is concentrated. But where do I absorb this water, sodium, and electrolytes? Tubules. But if tubules are damaged, no reabsorption. So you will have most of it being lost in the urine. So urine will lose water. So you will have low urine specific gravity in ATN. Then in pre-renal AKI, we will have casts. What are the casts we are getting in pre-renal AKI? The regular cast. What is the regular cast? Which is hyaline cast. We will only see hyaline cast. But when there is acute tubular necrosis, whatever cast that are being formed in the tubules, if I have acute tubular necrosis here, these epithelial cells will be shed and they will be impregnated on this cast. So we will form what is called as renal tubular epithelial cell cast or RTE cast. So we will have renal tubular epithelial cell casts. And these cells will go into apoptosis, release lipofuscin pigment, and the cast may become brown. So in that case, we will call that cast as muddy brown cast. So muddy brown cast is highly suggestive of acute tubular necrosis. But if they ask you what is the investigation of choice to differentiate between ATN and pre-renal AKI, that investigation of choice is going to be what can be the investigation of choice? Yes, the fractional excretion of sodium or FeNA. Now tell me where I will have more FeNA. What is FeNA? We will see out of the glomerular filtrate how much sodium gets excreted. So if there is pre-renal AKI, reduced perfusion of the kidney, there will be activation of RAS. And RAS will have aldosterone. And what aldosterone does? Aldosterone increases the reabsorption of sodium. So amount of sodium I excrete in urine will be less. Right? So fractional excretion of sodium will be low in case of pre-renal AKI. I will be absorbing most of it, excreting less. But where the absorption happens in tubules. So if tubules are damaged, absorption doesn't happen. So I excrete lots. In case of ATN, I will have FeNA increase. So FeNA more than 2% is suggestive of ATN. FeNA less than 1% is suggestive of pre-renal AKI. Right? So this is another important segment from the nephrology that I want you to remember. Right? Apart from that, if you ask me, sir, what should I by heart in the last minute? The definition of AKI and classification or the staging of CKD. Okay. Now a little bit on the pulmonology as well. From the pulmonology, what is important? Majority of the questions asked are about the PFT based diagnosis of the respiratory disorders. Right. So I'll just give you a flow chart for the PFT based diagnosis. So whenever I'm having a respiratory disorder, let us say, we know that we classify the respiratory disorders into obstructive and restrictive. So PFT is the investigation of choice for most of the respiratory disorders. And when I do PFT, first thing I should see is FEV1 by FVC ratio. If the FEV1 by FVC ratio is less than 0.7, it is suggestive of obstructive disorders. It is suggestive of obstructive disorders. What are the obstructive disorders that we know? First one we have is COPD. Second one is asthma. The third one is bronchiectasis. Bronchiectasis. And if the ratio turns out to be more than 0.7, it could mean two things. Either you have a restrictive respiratory disorder or you have no respiratory disorder at all. So then how will I differentiate? I will look at FEV1 and FVC values. Ratio is what I'm seeing first. If ratio is normal, then I'm looking at FEV1 by FVC independently. If ratio is low, it's always obstructive disorder. It doesn't matter what is happening with the values. Ratio is low, it is obstructive disorder. So then, if these values are low, then it is restrictive disorder. And if these values are also normal, ratio is also normal, values are also normal, then there is no respiratory disorder. There is no respiratory disorder. So in the restrictive disorders, right, what comes under restrictive disorders? I can have intrapulmonary restriction, extrapulmonary restriction. Intrapulmonary restriction is mainly interstitial lung diseases, right, ILDs. Pneumonia can also be considered as restrictive disorder. What are the extrapulmonary? I can have pleural effusion, pneumothorax. These are all going to be our restrictive disorders. Okay, clear? Now, the first line of MCQs that they are going to ask is, asthma and COPD are the most common obstructive disorders. How do you differentiate between them? Restrictive disorder differentiation is all image-based. Pneumonia, I can see it on the X-ray or HRCT. Pleural effusion, I can see it on ultrasound, X-ray, HRCT. Pneumothorax, I can see it on ultrasound, X-ray, HRCT. ILDs, I can detect them on the HRCT. So it's about imaging. But if it is obstructive disorder, how am I going to evaluate, right? So remember, if there is obstructive disorder, right? If there is an obstructive disorder, we have to go for a test called as bronchodilator reversibility test. We do what is called as bronchodilator reversibility test. So what do we do in this? We know that in asthma there is bronchoconstriction. It is reversible. In COPD there is remodeling of the airway. It is not reversible. So what we do is, we will have patients baseline FEV1 values available. We will administer a short-acting beta agonist like salbutamol, and then we will recheck the FEV1. We will call it as post-bronchodilator FEV1. And if the post-bronchodilator FEV1 increases by more than or equal to 12% or by more than or equal to 200 ml, if any of this criteria is met, we will call it as reversible obstruction. We will call it as reversible obstruction. And whenever we have reversible obstruction, it is equal to asthma. Asthma is the only condition where bronchoconstriction is reversible. But in COPD, it's not completely reversible. So it may increase, but not more than 12%. So if there is less than 12% increase, it could mean zero also, right? It is suggestive of persistent obstruction. Persistent obstruction can happen in two conditions. What are those? Persistent obstruction can happen in COPD as well as bronchiectasis. Now, based on the context and history, we can differentiate between bronchiectasis and COPD, right? Clear? Now we know how to approach the diagnosis. I will add just few points here. Interstitial lung disease, if I have to diagnose, what is the investigation of choice? It is going to be HRCT. And what HRCT shows? HRCT may show two patterns. One of them is called as UIP pattern. The other one is called as NSIP pattern. UIP pattern and NSIP pattern. So if I'm seeing UIP pattern, what does that mean? That is equal to seeing honeycomb changes. Honeycomb changes or fibrosis, traction bronchiectasis. NSIP pattern, if I'm seeing, that means ground glass opacities. Ground glass opacities. So which ILD is present with the UIP pattern? It is usually idiopathic pulmonary fibrosis that presents with UIP pattern. And which ILD is present with this ground glass opacities or NSIP pattern? One is non-specific interstitial pneumonia itself. And apart from that, the connective tissue disorder related ILDs like rheumatoid arthritis related ILD or SLE related ILDs, they present with NSIP pattern. Okay, few extra points. The UIP pattern generally carries poor prognosis. So if I get an ILD with a UIP pattern, those patients are going to have poor prognosis. If the HRCT shows NSIP pattern, this carries relatively better prognosis, or you can say good prognosis, better than UIP pattern. Okay, what is the investigation of choice for the pneumonia? The investigation of choice for the pneumonia is chest X-ray. Where? The lung, when there is pneumonia, it gets solidified. The alveoli get pus filled. So they may ask you what is the surest sign on the chest X-ray to show that there is pneumonia or lung being solidified, right? So definitive sign of consolidation, of the lung consolidation. What is it? It is presence of what you call as air bronchograms. If there are air bronchograms on the chest X-ray, it is highly suggestive of the lung consolidation. If it is in the context of acute setting in a patient with having fever, cough and all, it is suggestive of pneumonia. And what is the investigation of choice for pleural effusion? It is going to be ultrasound. Ultrasound can detect fluid less than 50 ml. What is the investigation of choice for pneumothorax? I better leave it to surgeon, but if I am the one who is actually handling a patient, ultrasound is good enough investigation to detect pneumothorax. Or you can also do HRCT, which can detect even tiny amount of air. Okay. Now, only extra thing I will add that can be asked here is, when we are dealing with a pleural effusion, the examiner may be interested in asking what you call as Leitz criteria, that is used to differentiate between the exudative and transudative pleural effusion. So what is the Leitz criteria saying? If more than or equal to one of three criteria present, that is equal to exudative pleural effusion. Exudative effusion. So what are those criteria mentioned in the Leitz criteria? I'm highly expecting that there will be a question on this. The first criteria that can be called as exudative is the pleural fluid protein divided by serum protein. The ratio of pleural fluid protein and serum protein, or pleural fluid albumin and serum albumin ratio. If it is more than or equal to 0.5, that means the pleural fluid has protein which is equal to or more than half of the serum protein, right? Then it is called as exudative. Second is same, pleural fluid LDH divided by serum LDH ratio. If it is more than or equal to 0.6, that means pleural fluid has 60% or higher of LDH than the serum value, then it is exudative. The third criteria is, if you have the pleural fluid LDH, if you have not tested the serum, then you can see if the pleural fluid LDH is more than 2/3 of upper limit of normal for serum LDH, then also it is exudative. Do I need to meet all the three criteria? No. If any one criteria is present, it is called as exudative. So in the exam, majority of the cases, first criteria will be met, that is protein. So then don't waste your time looking at the other criteria. Directly label it as exudative and move on. Only when protein criteria is not met, then you look at the ratio. Only when the LDH ratio is also not met, then you think about the pleural fluid LDH being more than 2/3 of upper limit of normal for serum LDH. One criteria met, pass on, right? That's the Leitz criteria. So that's it from my side today about a quick recap of the important topics from the medicine. This is not an exhaustive review. Those who want the exhaustive study from me, I have done a Reed Harrison series which we will be continuing. So you can start watching the videos starting from the symptoms that we started first. Now we are into individual diseases, right? So I'll see you in the next week when we take up another interesting topic from the Reed Harrison series. Till then, have a good time. See you soon. Bye-bye.